This is PT Pro Talk, the podcast for physical therapists who want to improve their clinical skills and be more successful. I am Ariana Parks, physical therapist and your host, and today I interview Dr. Suzanne Greenwalt, and she's going to talk about cardiopulmonary applied to all settings. Suzanne is a physical therapist with over 20 years of experience, geriatric clinical specialist, cardiovascular and pulmonary specialist, an associate professor at Ebonie University, and the director of clinical education in the School of Physical Therapy. In our discussion today, you are going to learn why all PTs are cardiopulmonary PTs, the importance of monitoring vital signs, and how to address cardiopulmonary comorbidities and basic things that you should keep in mind when treating these patients. So if you feel this information is valuable, please consider subscribing to our channel, clicking on the bell so you don't miss anything, give us a thumbs up, and share with other clinicians you feel might benefit from this information. I hope you enjoy the show. PT Pro Talk podcast is only possible with the support of the forward-looking and innovative companies like
Fitter First, your first choice for the best Canadian-made rehab and fitness products since 1985.
Hi, Dr. Suzanne. Welcome to PT Pro Talk. How are you today?
I'm great. How are you doing?
I'm doing well. And I'm glad to have you here to talk about a little bit of a different specialty that we have in our area. So let's start talking a little bit about yourself, your career, and how did you get where you are right now?
Okay, great. Well, first, thanks for having me. As you mentioned, my name is Suzanne, and I've been a PT for over 20 years. And when I first graduated from PT school, ironically, I really thought I was going to work in pediatrics, and that's the one area of PT I've not worked in. But I became really passionate about working with older adults and in acute care, and really that inpatient population very quickly once I started working. So my first job, kind of by default, was in acute care. And like I mentioned, I really did fall in love with it. And over time, transitioned from acute care and also did some inpatient rehab. And then eventually also in skilled nursing facilities. And what I loved about all of those populations was just the complexity of the patients. I really became passionate about being an advocate, especially for older adults, and addressing their comorbidities. Because as any PT knows, if you open a chart for an older adult, the list of comorbidities just goes on and on and on. And so that really led me to pursuing my geriatric clinical specialist certification. And as I was preparing for that and studying for that, the one thing that became so evident and just like on the back of my mind that I couldn't let go is that as you talk about geriatrics, especially the cardiopulmonary significance and the cardiopulmonary conditions are just everywhere. And as PTs, I felt like often what I was seeing in the clinic, and even to my own fault, was that those comorbidities weren't being addressed. You know, for example, someone comes in after a total knee replacement, but are we taking into consideration that they have CHF and they have a history of coronary artery disease, or maybe they have a history of COPD, and how do those comorbidities then essentially affect what we're prescribing for the knee? And is that even being considered? So after doing my GCS, I started looking a lot more into cardiopulmonary conditions, doing more research, more learning in that area, and then eventually also obtained my CCS, so my cardiopulmonary specialist certification. So since doing both of those, I've continued to work in geriatrics in the skilled nursing facility setting, and then also in acute care in Nashville, Tennessee. And I love working in acute care, especially the critical care areas, the ICU, and working with a lot of the really involved cardiopulmonary patients. Those patients aren't just older adults. Of course, we see all ages, and that's been really fun, and it's a great thing that I just love to do. And so been doing that, and then also teaching for the past 10 years. So been involved in DPT programs for 10 years now, and love teaching. I love being able to try to ignite some of that passion in my students for cardiopulmonary therapy and also geriatric therapy. And so yeah, that's kind of where I am now. My weeks are a mix of teaching and patient care, and I love that balance. I don't want to give up one for the other. I think that being with patients still enhances my teaching and vice versa. So it's a good blend.
Awesome. And I'm so glad to hear all these topics that you just mentioned, because I have a lot of questions about those, because we don't find as many PTs with those type of specialties. So I think that's very interesting. And I want to bring that to the outpatient setting, that I think it's probably most of the audience. So I know that you mentioned before that all PTs are cardiopulmonary PTs. So what do you mean by that?
Yeah. So I've often said that statement that like all PTs are cardiopulmonary PTs. And I'll say that to my students, because I'll have students say like, oh, I'm not excited to take cardiopulmonary class because I'm never going to work in cardiopulmonary. But what I always tell the students is that if you think about it, all of your patients have a heart, all of your patients have lungs. Like, we're all cardiopulmonary PTs. Like, we can't ignore what's happening in someone's cardiopulmonary system, because that ultimately is driving everything else in their body. So that's really what I mean by that statement. So what I try to emphasize with students, or when I'm doing like continuing ed courses that I'm teaching, is that to really think about what is going on from a cardiopulmonary perspective. So for example, does your patient have high blood pressure? And so what does that mean then for their treatment session? And as a PT, we need to make sure that we're giving them some education on that. Often we're the ones that identify that someone has high blood pressure. Not all patients are great about going to the doctor, right? Like, a lot of people don't see their PCP regularly. And so monitoring of blood pressure and other vital signs is an important role of all PTs. That's not just a cardiopulmonary PT role. And so I think that's something I try to really emphasize to students and therapists, is that regardless of the setting that you work in, there are significant cardiopulmonary implications in all settings. Whether that's being able to monitor heart rate and target heart rate and all that with your athletes, whether it's looking at those comorbidities in patients that are coming into outpatient ortho settings, whether it's thinking about maybe some of those congenital heart issues someone had that they've lived with their whole life, like how does that now affect them? The list really kind of goes on and on, but that's a big thing that I try to emphasize, is just taking a step back and thinking that all of your patients have a heart and lungs, and that's going to impact everything else that they're doing. And so we want to make sure we're being, mindful of that, and at least screening those body systems with all of our patients, which doesn't take any time.
Yeah, so that was going to be my next question. So if you have a patient that's coming in for like a total knee replacement rehab, right? And you go through their medical history, and you see COPD, you see high blood pressure, you see like heart disease, and even heart transplants, and all of those things that we know it's common with our older patients. So what do you recommend? Like, do you recommend, if they are in an outpatient setting, for example, go and measure the vital signs and monitor them through exercise? What do you recommend that the PT should be looking for or paying attention to?
Yeah. At a minimum, I would recommend taking baseline vital signs, when you have a new patient, to figure out what is their baseline. And having that baseline is so important, especially for heart rate and blood pressure, because that's going to help you determine then if in the future there's a problem, right? So if your patient one day, a future visit comes in and their blood pressure is really high that day, and they tell you they're not feeling great, you don't know if there's a problem or if that's actually their baseline, where they typically run a bit higher. So establishing what their norm is really important. It's important for us to know that as clinicians so we can see how they're changing. Because often with vital signs, it's those changes in heart rate and those changes in blood pressure that are going to give us the most information as to how the body is tolerating the activities or exercise that we're prescribing. So establishing that baseline value is definitely what I would do. And then if your patient is having, any symptoms that concern you, I would always recheck them. I think in like a healthy adult who doesn't appear to have any symptoms, doesn't have a significant cardiopulmonary history, it's not necessary, like especially in that outpatient ortho setting, to be checking vital signs like every day with every activity, right? I think that could be more than is necessary, but at least having that baseline so that you always can make that determination if they're having a normal response, or if, or if they start to have some symptoms or whatnot, that you can figure out, is that related to the cardiac system or the pulmonary system?
Yeah. So what patients that you suggest that we should check those signs? Do you say even like the healthy adults, and then all the ones that have like comorbidities? Like what is your standard?
As part of your evaluation, I would check everybody's vital signs, right? Heart rate and blood pressure are quick and easy to take. At a minimum, I would take those. And in your pulmonary patients, like especially someone with COPD, it would be great to take and get their oxygen saturation level. Just in some of your COPD patients run a little bit lower, that's their norm. It's good for you to have that understanding, again, that that's where they fall. But doing as part of your evaluation a quick vital sign screen, I would recommend for all patients. I know it's not the reality, be like, I'm not going to, act like I know, or I think that everyone does it, because I know they don't. And I've been at fault too. But I think that that's a really easy thing that as PTs that we can do that can make a huge difference.
And what would be the signs that would get your attention to kind of recheck while they're exercising, to see if there is something going on?
Yeah. So shortness of breath, that seems extreme for the activity that you're doing. They're more short of breath than what you would expect. Limited activity tolerance. And when I say limited activity tolerance, it's not that they're limited because, let's say they've had a knee surgery and their knee hurts, but that from an endurance or capacity standpoint, they feel like exhausted by what you're trying to have them do, and it doesn't seem to correlate. It could also be things like, chest pain. It could also be, if they have, for example, coronary artery disease, and they also have peripheral arterial disease, the patients may complain of pain in their lower extremities where they're getting some like claudication in that. So I would be mindful of some of those like big symptoms.
And what do you feel is acceptable? Like, what should we just let them rest and recover? Or like, what are some levels that you feel like we should refer them back to the doctors or stop the activity?
Yeah, definitely. If you're working with a patient, and again, it depends on the setting, diagnosis, all of that sort of thing. But if your patients, you would expect that your patient's heart rate and blood pressure would increase with activity. That would be a normal response. When you're doing exercise with any patient, if the heart rate goes down or stays stable, that's a sign that the heart is not tolerating the activity, right? It can't keep up with the needs of the body. The same with blood pressure. Your blood pressure should increase. From a systolic perspective, we typically see your systolic blood pressure go up with activity. With endurance-based activities, it'll rise initially and then level off, which makes sense because if you think of like a marathon runner, their systolic blood pressure is going to increase when they start running, but then it levels off. It's not going to just keep steadily increasing the whole time they're running. And your diastolic blood pressure should go up or down 10 millimeters mercury with activity. And so there are other, heart rate parameters depending on the level of activity, of course. And a great thing for clinicians to use if you're worried that maybe the patient's cardiac status is such that, you really want to monitor that heart rate. Specifically, you can always use a formula like the Carbone formula and figure out their target heart rate and where they should be exercising, and then monitoring their heart rate and keeping them in that range. And when they fall too high, either you're pushing them too much and need to back off a bit, or that there, could be something going on. But in general, if we're talking just basic screening, taking vital signs at rest, and then as a PT, when do I get concerned? I would be concerned with those patients who become symptomatic with activity that it doesn't correlate with.
Yeah. So you're just looking for a different reaction, or like out of the normal reaction, because you expect you're working. I had on the clinic like a 96-year-old man that he needs to take breaks to do his exercises. But I mean, like that's, I guess, expected for his age. So like it's just sometimes you have to use your normal sense, or just your to kind of identify if that's an issue, or it's just, I had a 80-year-old yesterday need to take several breaks to complete his exercises. But I didn't think about monitor his like vital signs, and now we are talking and I'm thinking about like my patients that maybe I should be monitoring and I'm not, because sometimes you just forget about it. You're just so focused on the orthopedic side of things that like I don't even think much about it. But they have a lot of the patients have a lot of comorbidities, and you just see their medical history and you're like, well, maybe I should be paying a little more attention to those things when I'm treating them.
A great example of all this is several years ago, I had a PT who I knew who worked in outpatient ortho, and she was telling me she had a patient that she was treating who was post some type of leg surgery. I think it was her knee. She was pretty young though. She was in her 40s, and she had taken the patient's blood pressure on her first visit and her heart rate. And the patient did have like a history of an arrhythmia and some, I would consider, smaller cardiac history, but enough that she had a relationship like with a cardiologist. So anyhow, fast forward a few treatments in, one day the patient comes in to therapy and just tells the PT, like, I don't feel good today. Like, I don't have anything specific. She just in general said she did not feel great. And the PT took her blood pressure again, and her systolic was up like 60 millimeters mercury higher than where it was for her normal baseline. And she called the cardiologist. They ended up sending her to an ER, and it turned out she was having an MI. And like the PT caught that.
My God.
That's amazing, right? Because especially with women, there can be no other signs. Like sometimes there aren't specific signs other than like fatigue and just not feeling well. Well, we're all fatigued. Let's be honest. Like we're all busy and working and doing all the things, all right? And so like I don't always get alarmed when someone tells me that they have fatigue, but because she had that information from her blood pressure, also she was able to say like, holy cow, like something's going on here. I should at least call the doctor. And so I think it's just a good example of, something really simple like checking blood pressure can make a huge difference.
And like in your experience, if you're working with these patients in like outpatient setting, and they have those like they have the shortness of breath and some other signs, would you suggest any like exercise or anything that we could give to those patients to address those needs, since we don't have, at least I imagine most outpatient PTs don't have much experience or sometimes don't know what to do? Like, do you have some tips that would help us in our treatment to address those other issues?
Yeah, definitely. So any of your pulmonary, like patients who have a pulmonary history who complain of shortness of breath or having like dyspnea on exertion or dyspnea in their sessions, one of the most effective breathing techniques for that is pursed lip breathing, which I think a lot of therapists tend to use and don't even realize, truly the significance behind it. Cueing the patient to like breathe in through their nose and then blowing out through pursed lips. And that is a breathing technique that is very effective at helping to control dyspnea. So again, your patients who have a pulmonary history, that can be a really great technique to keep in mind if they're getting short of breath. So that's a really good one. Another thing to think about is somebody who has COPD, like specifically emphysema. A lot of your patients with emphysema tend to be upper chest breathers. You often see that they have like really elevated shoulders and they're kind of rounded forward here and they're hypertrophied in their accessory musculature. And so they're not using their diaphragm as well. So even encouraging diaphragmatic breathing or teaching them to use diaphragmatic breathing, because that will help to improve the air and like the oxygenation that is getting in throughout in their body. If they're moving more air into their lungs, they're going to get more oxygen and that out into the body as well, which will help improve their activity tolerance. But yeah, I think it's really important with all of our pulmonary patients for us to kind of take a step back and just watch their breathing. What does their breathing look like? And if they are getting really short of breath, to give them those cues of pursed lip breathing, of course, letting them take adequate rest breaks. A lot of your pulmonary patients too with shortness of breath or with dyspnea will rely on, what we'll call like a tripod position or professorial position, where they're leaning forward on their forearms. And I know you can't really see me there, but leaning forward on their forearms, like resting them on like the armrest of a chair, or resting them on their thighs. And you'll even see patients do that with a walker, where they lean forward and are resting their forearms on the walker. And I think our initial instinct as PTs is like, sit up straight, sit up, get out of that posture. Because it's this like forward flexed posture. But that technique also helps to control symptoms of dyspnea. So it can be another technique to use with patients to try to help manage the dyspnea. So I think just being aware of some quick and easy things that you can instruct your patients on to try to help control shortness of breath if they have that in their history. Because I think too often pulmonary patients especially, they appear to have very limited activity tolerance. And I've heard PTs say like, I just don't really think they're appropriate for PT. They can't tolerate a lot. Like the stuff I would normally do with this patient, I can't do with them. But I think if we as healthcare providers take a step back and help them work through some of the pulmonary symptoms, and they typically are able to tolerate a lot more of the activity.
Yeah, so that's how I was asking for those tips, because sometimes we are already spending so much time with them, and if you knew some like useful, helpful tips like that, just help them get the most out of the session so they can tolerate exercise better and be able to do more in a visit.
Yeah, absolutely. I mean, because I think that's the goal for all of us, right? Is that we want our patients to be able to do more, to be as functional as possible, to work through whatever their impairments are and functional limitations. And when there are those cardiopulmonary comorbidities that can really slow someone down, and a lot of times those can be addressed, pretty easily. And I know we don't do a lot of like endurance training. It's not always something that's widely approved, if you will, in the PT realm, right? Like patients can't come just for endurance training, but it's really important that all of our cardiopulmonary patients, anyone who has a cardiopulmonary history, is involved in aerobic type training, right? That's really important for the heart musculature and for their body. And so I think even if we're not doing that with a patient, like in an outpatient setting, for example, but encouraging your patient, like, let's talk about what your daily activity looks like. How many times are you walking? How many times are you getting on your bike or doing this, and making sure they're engaging in that type of aerobic activity as well, because that's a really great thing for them to keep up with. And of course, if they've had some type of orthopedic issue, it's great for that too.
Would you like, now I'm just see like what you think about that, but would you like to maybe just mention a few of the most common like comorbidities and how you'd address those in a more specific way to each of them? Or I don't know if what you just said was just general and would be true for all of them, or if you want to be a little more specific on each, or if you have any specific tips for each type of comorbidity.
Yeah, so we can talk CHF, like heart failure first. Heart failure is very, very common worldwide and is a leading cause of death. Heart failure, essentially, if you were to put it like in layman's terms, just means that the heart muscle can't keep up with the needs of the body. So it's the heart is failing, right? And so essentially, there's not enough blood and oxygen being pumped out of the heart to meet the needs of the body. So the patients start to have fatigue and limited activity tolerance. And the specific symptoms that you can see on their body, like the physical impairments that you see, really vary depending on where the heart is failing. Meaning, like, is it left-sided? Is it right-sided? Is it a mix of both? But with heart failure, you can see patients who have significant pulmonary deficits, meaning they're short of breath. They have very limited activity tolerance. They're, complaining of dysbionic exertion. They can't lie flat. And that's because the left side of the heart, like the left ventricle, is not getting all of the fluid pumped out as it should. And so it starts to back up. And if you think through normal circulation, where it's going to back up is into the lungs. So your patients with left-sided heart failure tend to have a lot more pulmonary symptoms. So again, with those patients, you're going to see that shortness of breath and limited activity tolerance. So from a PT perspective, we need to be mindful of, again, working on those breathing techniques. It can be pursed lip breathing. You could work on diaphragmatic breathing. But you're going to have to just be really mindful that their endurance is going to be affected because of all that fluid. And then if it's the right side of the heart that is failing, that can be just in and of itself, like standalone right-sided heart failure. It could also be because the left side of the heart is failing, that fluid and that backs up into the lungs, and now it kind of affects the right side of the heart as well. And those patients are the ones that we see that get the bilateral lower extremity edema. They'll get that edema in their abdomen, the jugular vein distension as that fluid backs up out into the periphery. So with CHF, the big challenge that I see so often is that therapists will say, like, I can't do anything with them. They have all this fluid. They're short of breath. It hurts for them to move. It hurts for them to walk. Their lower extremities are so swollen. There's fluid weeping out of them. Like, what am I supposed to do with them? And CHF is one of those diagnoses that I think as PT, we just need to be really mindful that these patients are going to be a slow process because that fluid balance is so important. Anybody who has CHF is going to be under the care of a physician, or should be. And so these patients, there's a delicate balance when that fluid starts to accumulate. With CHF, we see that a lot of those patients also have kidney involvement or have kidney impairment. So you can't just load them up on diuretics and send all that fluid to the kidneys because that can exacerbate the kidney issues. And then I've heard people say, like, well, could we just put like compression stockings on their legs? And you can't do that because that's going to compress the legs and send all the fluid back to the heart. And the heart's already failing. So now we're going to overload the heart. So it's this very delicate balance.
Complicated.
Very complicated. And so the medical team, either there's a delicate balance there with the medical team of managing that fluid. And of course, that's more in like acute exacerbations. But on a day-to-day basis with someone with CHF, the big thing I think that all therapists should be aware of is talk to your patients about, like, are they weighing themselves daily? That is a gold standard with CHF. Those patients are supposed to weigh themselves every single day, the same time of day. And if their weight has gained more than 3 pounds in a 24-hour period, that is a red flag, and they need to let their cardiologist or physician know, because that can be a sign of a CHF exacerbation, right? Because that weight gain is directly correlated to the fluid that they're retaining. So that's a big thing. The daily weights, I think that patients often don't get enough education in that, or if they're educated on that in acute care setting, it's like crazy in the hospital and they don't remember to do it. Some patients don't even have scales. And then I always ask questions like, can they even see the scale numbers? What's their vision if it's an older adult, or their mobility good enough that they can step on and off of the scale? Like, those are things as PTs too that we can just be inquiring about. But I think in an outpatient setting, the biggest thing there is just talking to your patients about their CHF. Do they know how to manage it? Do they know what they're watching for? Do they know if their shortness of breath gets worse, significantly worse, they need to let their doctor know. If their edema gets worse, they need to let the doctor know. If they have a more than 3 pound weight gain, they've got to let the doctor know. So I think the big thing with CHF is that education. It's just making sure the patients know what to do. Because that's the diagnosis. We see so many hospital readmissions because patients are struggling to manage it at home and don't know what they're supposed to do.
Yeah, that's great. great for us to also keep them on track and ask those questions if they happen to be in our care. So
Yeah,
very helpful.
absolutely. And I think, another diagnosis that we see a lot of in adults is COPD, which COPD is kind of, an overriding term that underneath that you've got emphysema and chronic bronchitis, which present very differently, but the underlying issue is the same in that the air is getting trapped and can't get out of the lungs. So when you talk about pulmonary diseases, you've got restrictive diseases and obstructive diseases. And COPD, chronic obstructive pulmonary disease, of course, is an obstructive disease, meaning that the air is getting trapped in the lungs and the patients are having difficulty getting it out. And that's kind of the opposite of what's happening with conditions like pneumonia, where patients have difficulty getting air in. So they're a little bit different, but a lot of the treatment is the same. So with your patients who have COPD, again, things like pursed lip breathing are very effective. Aerobic activity is really important. Strength training is really important. Looking at posture is important. With all of our pulmonary patients, looking at posture is really important because if someone has really rounded shoulders and is kyphotic and always leaning forward, yes, it'll help your dyspnea if you're in that tripod position, but if you're in that all the time, you're going to start to see postural changes that ultimately are going to affect the ability of the lungs to be able to inflate fully and to be able to expand fully. So then it just creates this bad cycle for these patients. But for your COPD patients, you'd also want to be thinking about, do they have thick secretions in their airway? Because when the air gets trapped, we also see secretions getting trapped with patients who have chronic bronchitis. So these are your patients, that come into therapy and they have just like that yucky cough that's productive and most people are kind of grossed out by it. But we want to make sure that our patients can even cough effectively. Like, are they able to cough it up? Are they able to expel those secretions, right? And I think that's way more than you would dive into in like an outpatient setting, but being mindful, like if they've got a lot of secretions that they're not able to expel, they need some education on how to strengthen their cough and what they can do for that, because that's just going to lead to infection and other complications. So I think from a PT perspective with pulmonary conditions, it's also us just being mindful of, are they having increased shortness of breath? The Borg scale of perceived exertion is a great tool to use to measure how hard your patients feel like they're working. So as you're prescribing exercises, is the way the patients are rating it, does it appear to correlate with the level of activity you're prescribing? Because it'll give you an idea, of how deconditioned or how much this pulmonary condition is really affecting them. Being mindful of their oxygen saturation levels, being mindful of their breathing patterns. That way we can have those conversations with them about doing deep breathing to engage the diaphragm, doing pursed lip breathing to relieve some of the dyspnea, and, just trying to help them, again, have some control over that diagnosis.
Yeah. And when you mentioned the aerobic component of the COPD, is there any specific recommendations for the aerobic?
In the literature, like the most effective form of aerobic activity pretty much for all of these cardiopulmonary conditions is walking. So, just again, I don't anticipate or expect that like all PTs are going to just be going on huge walks with all of our patients, although it would be nice. But I think just really encouraging our patients, if they're able to walk as much as possible. I think what I see with pulmonary patients is that they're terrified that they're going to become more short of breath. Feeling like you can't breathe is a terrifying feeling. And so a lot of patients will self-restrict. They'll stay home, they'll stay in their recliner chair where they feel like safe and that they can breathe and they can be in a position that works for them, but they really restrict themselves. And then it just creates this cycle, right? It makes things worse because now they're getting more deconditioned. Now their muscle strength is decreasing. Now we're affecting activity tolerance even more. And so trying to encourage patients and educate them that maintaining aerobic activity and doing, strength training if possible, that those two things will truly help the symptoms that they're so terrified of.
Yeah. And then do you recommend them monitoring anything when they are walking, or just walking to their tolerance and then take as many breaks as you need to?
It really depends on the patient, but for pulmonary patients, a lot of them will have O2 stat monitors at home, like have portable ones they can just put on their finger. And so if they have that, that's great for them. Most of like the COPD patients I see, they kind of have that knowledge, they have that understanding, they probably already have that. But if not, it could be a good discussion just to even have, like, do they even know how to interpret the numbers on it? Do they know what numbers they're even looking for, right?
Yeah. Okay. And on the cough to be effective, any tips for us to educate them?
Yeah. Interestingly, there's some good studies out there that even say that aerobic activity can help you to have a more effective cough. So again, we're going back to linking that together, that we need to stay active to help move the secretions. And so that's a huge thing. Another, there's some great breathing exercises out there. But it's probably one of the simplest ones is to encourage your patient to take a really big, deep breath in so that they're getting air below the level of secretion, and then try to cough them up. So I'll cue patients like to put their hands on the side of their rib cage, and they want to inhale fully so that they feel their rib cage coming up and out, and they should see their hands rise, and really wanting to get that air down below the level of the secretions to try to help cough them up. Another simple thing I'll educate patients on, especially if they have those secretions in there that they're trying to get rid of, is to make sure they're staying hydrated. Because if you're hydrated, the secretions are going to be thinner and it's going to be easier to expel them. And it's fascinating to see, how little water a lot of people drink. A lot of our patients don't drink that much water. Again, especially someone who's not getting up and down a lot at home. They may not get up many times throughout the day to refill their water cup, but hydration is a big one.
Yeah. And then strengthening wise, any specific recommendations or just general strengthening?
General strengthening. Yeah. General strengthening.
Okay. Good. Maybe some core strengthening so they can cough.
Yes. Yeah.
Good. Any other like big disease that you want to talk about other than the ones that we talked?
I don't think that right now we should probably go into heart attacks, like MIs are of course.
Yeah.
But that's a whole nother level of therapy, right? Because there's in cardiac rehab and have all of that. I think the biggest thing I would say about someone who has a history of coronary artery disease or has a history of having had CABGs or having had MIs, if you're seeing them in other practice settings, that's another patient that I would definitely get those baseline vitals and then be mindful of any symptoms, right? Like their blood pressure is not responding appropriately, like it's going up too high. If they're complaining of new onset chest pain, any of that, I would certainly refer them back to their doctor.
Awesome. Okay, I think they're all great tips that apply to our setting and all the basics that it's just good to know. Before we transition to the final questions, anything else that you want to add to these general practices, tips for all settings?
No, I think it's a great conversation. It's a great place to start, and I think at a minimum, if you're checking your patient's vital signs and just paying attention to their medical history and just being aware of it, I think is a great place to start. Sometimes I think it's hard for us as PTs to even get them accurate medical history and to really know what all their conditions are. But the more we can strive to do that, that'll just benefit the patients greatly.
Yes, absolutely. And what is your favorite resource of information? Anything that you like in particular that you recommend us?
That's a good one. I love the information that is put out by the APTA and the academies of the APTA. So I follow on social media, like Cardiopulmonary Academy and Geriatric Academy and Acute Care Academy and all of those sections in the APTA. They often reference and highlight journal articles that maybe have new information, new studies, new, new treatment techniques. So I love, relying on our professional organization. I think that there's a lot of great resources through our professional organization. I also love, even on social media, following PTs. Like, I try to follow as many PTs as I can. I think we have some phenomenal therapists in our country that are and around the world that are highlighting what they're doing and what they're doing with patients and highlighting cases and sharing so much on social media. And granted, that information, of course, it's not peer reviewed. It's not like published information, right? But they're sharing what they're seeing on a day-to-day and what's working in their practices. And I think we can learn a lot by relying on each other. There's so much knowledge in our profession that I love to rely on seeing what other PTs are doing as well. So no, I don't have like a, favorite study or paper or that sort of thing. One thing I do love from a cardiopulmonary perspective is for like new grad therapists is there are entry-level competencies out there that give you an idea of all the things from a cardiopulmonary perspective that you should be competent and comfortable with upon being a new PT. And I think that document in that paper that's been published is even a great thing for all PTs to review and to kind of think back, because I'm sure there's a lot of us out there that have been out of school for a long time that you just forget some of that stuff, if you're not using it all the time. But I think that's a great resource if you're looking specifically for like something cardiopulmonary.
Awesome. And what would be the best advice you can give to clinicians that are starting their careers? You kind of just gave that one. Any other one?
I would say like find your passion. Like we have the beauty of being in a profession that has so many different settings. I meet PTs all the time. They're doing such unique things. Even like students of mine who have graduated, and I'll like when I hear what they're doing, I'm like, it's amazing. From pelvic health to concierge type PT to home health to critical care to working with sports teams and pro teams and high school athletes. I mean, it's all over the spectrum, right? But there's so many ways to be a physical therapist that, my advice is to just find your passion. If you don't love exactly what you're doing, it's okay to search out other things within our profession, that there's so much opportunity and so much need, that find your passion, because there's so many patients out there that need us.
Yes. We have so many options out there. And what personal qualities or abilities that you think are important to become a successful PT?
I think PT success for me has always been, I think about being a team player and the love for your patients. It's so much more about that personal connection that a therapist can make versus being the person who in PT school was the 4.0 student. Like I'll tell that to students all the time, that once you graduate and you pass your boards, nobody cares if you were the student who had an A in all of your ortho exams, or if you were the student who, got by an ortho just by the skin of your teeth. Like nobody knows, nobody cares. Like if you've learned the information and you know how to implement the information and you've passed your boards and you are good with patients and you are good with your colleagues and you're a team player, and you're passionate about what you're doing, that is going to take you farther in this profession than any book knowledge will. I think, so for me, I think a PT is a helping profession. It's a people profession. It's a profession where we, give a lot of ourselves, and have to have a lot of empathy for our patients and really care for them. And I think those personal qualities, those are all individual qualities. And those are what's going to take people the farthest is therapists who kind of can do that for their patients, their colleagues. I think we work now. It's a tough time in healthcare. Like, let's be honest, it's been a tough couple years for healthcare providers, and in all areas of healthcare, we've seen people leaving professions. And I think we've got to have each other's backs, right? We've got to be there to support each other, help each other. And those are things that are going to help you go far in your career, is being that team player, not only for your patients, but also for your colleagues.
Yes, absolutely. Because if you don't have those skills, doesn't matter how much you know, if you can interact, have empathy, and help your patient, it doesn't matter, right? Suzanne, thank you so much for your time and sharing all your knowledge. I appreciate it. And if people want to learn more about you or find you, how they can contact you.
Yeah, definitely. So I'm happy to share my email address. It's Suzanne, which is SUZANNE color green, and then WALT at 𝐵elmont.edu. And that's my email address. So feel free to reach out to me via email. And yeah, that would be great. And one of my goals for this upcoming year is to, develop a professional social media accounts. And so I plan to do more of that. I am on LinkedIn as well, just under my name.
Well, it's a lot to do. Like social media does, it's a lot. So you gotta.
I'm like, I don't know if I can keep up.
It's just one more thing on your list. Well, thank you so much. I appreciate all your availability and sharing with us all these great tips to help our practice and our profession. Thank you so much.
Oh, thank you. This was great.